ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. This is Dr. Manjunath Awadkhan. Welcome to my YouTube channel again. Let's learn medicine together and in a very simplest possible way. Today I will be discussing about papilledema. It's a neurological emergency which can be diagnosed bedside by ophthalmoscopic examination. This is the image showing normal fundus finding. Macula is temporal and inferior to optic disc. Introduction: it's a swelling or edema of optic disc secondary to raised intracranial pressure. So etiology will be conditions causing raised intracranial pressure such as brain tumor, other space occupying lesion, sinus thrombosis, hydrocephalus, meningoencephalitis, pseudotumor cerebrae. Papilledema can be seen in acute as well as chronic raised ICT features. It can occur in hours to days, most commonly seen in chronic raised ICT. Eye is a window to the brain. Anatomically and developmentally, the retina is an extension of CNS. Several neurodegenerative conditions affecting brain and spinal cord have manifestations in the eyes. Ocular symptoms often precede conventional diagnosis of CNS conditions. So it's very important to do complete ophthalmological examination and fundus examination. In CNS cases, fundus examination is must. This is the image showing pathophysiology of papilledema. This diagram shows normal anatomy of the optic nerve, optic sheath and optic disc. So whenever there is a raised intracranial pressure, that means raised CSF pressure, which will leads to raised CSF pressure in optic sheath CSF. This pressure transmitted to optic nerve tissue, which will leads to stasis in exoplasm, which will leads to papilledema and secondary vascular changes due to venous congestion. So this diagram shows papilledema secondary to raised intracranial pressure and raised optic sheath CSF pressure, leading to compression of the axonal transport. So this diagram also shows pathophysiology of the papilledema. So whenever there is a raised ICT, leads to exoplasmic stasis, which will leads to optic disc swelling, that is papilledema. And due to axonal stasis and optic disc swelling, there is a venous obstruction, which will leads to secondary vascular changes such as retinal hemorrhage. So whenever there is a chronic papilledema, chronic axonal compression, and finally hypoxia and gliosis, which will leads to optic atrophy. Note: papilledema is purely hydrostatic change in optic disc, which is non-inflammatory. Symptoms of papilledema: mainly features of raised ICT such as headache, nausea, vomiting. These features are more pronounced in early morning when patient wakes up. There can be transient obscuration in vision, which lasts for seconds and associated with postural changes. Usually vision is normal in acute conditions. This is an image showing normal fundus. This is optic disc. This is macula. Macula is inferior and temporal to optic disc. These are the vessels coming and going into optic disc. This is optic nerve surrounded by optic sheath with CSF. So whenever there is raised ICT, which will leads to raised CSF pressure in optic sheath, which will compress a optic nerve, which finally leads to exoplasmic stasis and finally to papilledema and venous congestion. Ophthalmoscopic findings of papilledema. So this is the normal fundus examination showing normal optic disc. So in case of papilledema, there is edematous blurring of disc margin. There can be hyperemia, disc edema. There can be obliteration of optic disc and elevation of optic disc. Due to elevation of optic disc, whenever a clinician ophthalmoscopically focuses retina, disc is not visible. So whenever clinician focuses disc, retina is not visible. That means there is a bulging in optic disc. Both are not at same level. There can be capillary congestion. There can be generalized engorgement of the veins. There are loss of spontaneous venous pulsation due to venous stasis. And due to venous stasis, there can be hemorrhage, which can be punctate and flame shaped. In advanced cases of papilledema, edema may extend to macula, producing fan or star shaped figures, which is known as star macula. Patterns line. These are peripupillary concentric wrinkling in retina. As edema reaches periphery, there are concentric wrinkling in the retina, which are known as Patton's line. So this is a diagram. This is an image showing there is a papilledema with the disc margin is lost here, no differentiation, and these are the Patton's line, concentric wrinkling. This image is taken from Nelson, showing grades of papilledema. There are 6 stages, stage 0 to stage 5. Stage 0 being normal fundus finding and stage 5 being severe form. And here is the image showing macular star in stage 5. Whenever there is a chronic raised ICP, that means prolonged sustained papilledema, which leads to permanent nerve fiber damage and optic atrophy of disc with macular scarring. That means there can be loss of vision. So whenever there is a raised ICT, there can be a papilledema. So we treat raised ICT. So gradually raised ICT settles, which leads to settling of the papilledema, and optic disc returns to normal or near normal within 6 to 8 weeks. So differential diagnosis for papilledema are pseudopapilledema, optic disc drusen, disc swelling in papillitis, hypertensive retinal change, diabetic retinal change. In papilledema, central vision usually preserved in case of acute papilledema, and absence of Marcus-Gunn pupil and apparent pupillary reflex helps to differentiate acute papilledema from acute optic neuritis. Papilledema is a neurological emergency, so neuroimaging should be done. If no intracranial mass or other pathology detected, a lumbar puncture and determination of CSF pressure should be followed. Thank you.